Hi there, I'm Dr. Brigid Norton. You can call me Brigid. This is Menopause Bytes, where I unravel the mysteries of menopause for you in bite-sized episodes. Today, let's talk about the estrogen component of hormone replacement therapy, which we now call hormone therapy. Hormone therapy usually involves estrogen, and if you still have a uterus, progesterone as well. The primary goal of the estrogen component is to treat menopausal symptoms like hot flashes and night sweats. We tend to prefer the bioidentical estrogen, which is chemically similar to the estrogen our bodies produce, but not identical. Bioidentical estrogens are derived from plants, but must be chemically modified to become the bioidentical estrogen, so they are not a completely natural product. Currently, there are 4 bioidentical estrogens available in the US. We prefer using FDA-approved estrogen products because they undergo rigorous safety testing as well as ongoing monitoring. So we know what we are getting is safe, reliably being absorbed, and dependably giving us the same dose each time. Estradiol is the primary FDA-approved bioidentical estrogen we use. Another FDA-approved bioidentical estrogen is Estradiol, which is currently only available in birth control pills and not yet for a menopausal product. We generally avoid using the other 2 bioidentical estrogens, Estrogen and Estradiol, which are often found in compounded hormone products. These estrogens are not FDA approved due to lack of safety data, and they're also weaker estrogens, so you need a higher dose to achieve similar results that you'll find with estradiol. And as a reminder, we don't recommend compounded hormone products because of safety concerns around that lack of regulation and ongoing monitoring. Another FDA-approved estrogen for menopausal hormone therapy is Premarin, which is derived from the urine of pregnant mares. While it is actually the only natural estrogen available, it is not bioidentical since it differs from human hormones. Premarin is as effective in treating menopausal symptoms as the bioidentical estradiol. However, it has become less popular, particularly after the Women's Health Initiative study findings, primarily because of the marketing around the term bioidentical, but also related to the fact that it's only available in pill form. We generally avoid estrogen pills when we can, whether it's the bioidentical estradiol or the non-bioidentical Premarin, because pills pass through the liver, which can stimulate clotting factors, can affect your blood pressure negatively, affect parts of your cholesterol like LDL and triglycerides, and potentially decrease your sex drive. We also know that pills tend to cause less stable blood levels of estrogen throughout the day. However, there are cases where we may still use the pill, and if you're under 60, the associated risks are likely minimal. That said, there are many reasons why it's preferable to use an estrogen patch and avoid the pill if possible. Many women presume we will start with a dose of estrogen based on hormone testing, which definitely sounds like a good idea but is not based on any science. We don't have an estrogen level we're aiming for, as we don't know what estrogen level will give you symptom relief. Instead, we're aiming at treating your symptoms. So, if you are going through menopause at the usual age, we typically start with a standard dose of the 0.05 milligram estradiol patch, or equivalent if you're using other forms of estradiol. This dose has been shown to provide symptom relief for about 80% of women based on scientific studies. For those of you with premature ovarian insufficiency, or POI, that's menopause before the age of 40, we would start with a higher dose of estrogen, usually the 0.1 milligram dose of the estrogen patch, or equivalent if you're using the ring, gels, or spray. And sometimes we need an even higher dose than that. Usually, we see an immediate improvement in some or all of your symptoms in the first few weeks after starting hormones. However, it can take a full 12 weeks to see the full benefits, so we usually wait until that 3-month mark before making any dose adjustments. Vaginal estrogen does not necessarily treat hot flashes and night sweats. In fact, only one vaginal estradiol product does treat body-wide symptoms, and that is the Premarin. The other vaginal estrogen products are a much lower dose and are only meant to treat local symptoms such as vaginal dryness or discomfort with sex or recurrent bladder infections. And then the final thing to point out about estrogen is that not everyone can take it. For instance, if you have a history of stroke or blood clot, have a clotting disorder, have heart disease or significant liver disease, or have an estrogen-dependent cancer like breast cancer, you will likely be advised to not use estrogen. I will post a separate episode on who can't take hormone therapy. So that's it for another episode of Menopause Bytes. Here are some take-home bites to remember. Estrogen is the component of hormone therapy that best treats those body-wide menopausal symptoms like hot flashes and night sweats. We prefer FDA-approved estrogen products because of rigorous safety testing, and we prefer the bioidentical estrogen as it is most similar to human hormones. We prefer to avoid the pill as it goes through the liver. That usually means our estrogen of choice is the FDA-approved bioidentical estradiol in the patch, gel, ring, or spray form. And finally, we use standard dosing of estradiol to start with, based on studies that show that 80% of women get symptom relief at that dose. Until next time, may your hot flashes be bearable, your nights restful, and your thermostat easily adjustable.